Very similar to what Brian was discussing. It was really clear to us that we had moments in our careers and our lives as physicians and also other clinicians that were where we were extremely vulnerable to feeling awful. And we also noticed that it was a time when we tended to leave each other alone for lots of good reasons, but reasons that we now understand are not justifiable. So our institution had recognized this, and we looked to start a peer support program modeled originally after the first responders, who have a very, very long tradition of being there for each other very explicitly and assertively after any of their members experiences anything potentially stressful, emotionally stressful. So these are the firefighters and the EMTs and the police officers. And we actually had them come and train the first cohort of peer supporters to be able to reach out to each other after something had gone wrong. Again, it was in the context of what Brian said was we were noticing there was so much stress, especially after adverse events. The other thing that we started to look at very carefully was, in trying to design a peer support program, was, well, what are the emotional impacts after adverse events? And what we discovered, and I think this has been well borne out in the literature, is that, first of all, it's very individual what somebody feels, but it's quite common that we have some emotions that we all share as clinicians. And just going over them in general, one is, of course, we're sad. I mean, we're sad to see another person suffering. Followed by that is a real deep sense of shame. And I think the shame has really gotten in the way of our recovering after adverse events. And so you have to look at, well, why would we feel ashamed after an error? And there was a researcher named Helmreich who actually looked at the similarity between the enculturation in aviation and that in medicine. And he found that both stress a need for perfection and a deep sense of personal invulnerability. So if we are trained to be perfect, that is, we have expectations of perfection, which is completely unrealistic. Humans make errors at actually quite predictable rates, but if we're trained to believe that we really should be perfect, then when we're not, it's really hard to reconcile. And that feeling is often turned inward and to ourselves as, I am deficient, I'm bad, I'm not qualified, I'm incompetent, I shouldn't be doing this work. And then as a profession, we've been trained to look at each other that way after adverse events, because, we just can't see that in our colleagues. So the other very important factor is that medicine actually selects for perfectionism and grooms us to be perfectionistic. And perfectionism itself is a risk for a lot of bad things like depression, anxiety, burnout, and even suicide. And the suicide rate in both men and women physicians compared to the normal U.S. population is absolutely astronomically higher. And again, we all feel like we have to start doing something to prevent that. And this is a form of prevention. So the other emotions I think that a lot of physicians and other clinicians feel, one is fear. And the fear, there's a lot of reasons to be afraid after something goes wrong. One is that we have a really long-standing devotion to our patients and hope that they trust us, and usually they do. But when something goes wrong, especially if we've made an error, there can often be a sense of mistrust by the patient or even the patient's family, which again is that's up to them. They are entitled to feel whatever they feel. But for us to have that breach of trust and to have a patient or family be angry at us or not trusting is it feels very damaging to us. And I think there's another fear, and that is that even though we're supposed to now be not a shame and blame culture, we still are. And even if in our own medical institutions we got past the shame and blame, which we're working very hard towards doing. Society is shame and blame. What's the malpractice system but a very specific shame and blame? It doesn't really look at systems when things go wrong. It looks to who can we blame and who can we punish. And so there's a sense of betrayal, I think, by our, sometimes by our colleagues, but really more important by society itself, that is this what's supposed to be happening afterwards? And I think that can, all of these emotions can lead to a real sense of being isolated. And as we all know, being isolated, humans are really social animals, and being isolated is unbelievably stressful and something we should really try to avoid. Mm-hmm. So I think peer support really speaks to dealing with this sense of isolation and trying to prevent it. I mean, anytime we talk about peer support, I think all of us hold in our minds the people who are most important to support after something goes wrong in any way, shape, or form would be the patient and the family. Clearly, they deserve the support. What we do recognize now is that for us as a healthcare team and individuals, for us to provide that support, we ourselves have to feel whole. And that, I think, is why peer support is so important, because at the end of the day, if we can be supported and we can feel whole, we can do a better job at being transparent and compassionate with our patients after something goes wrong. And also, we want to recognize that the team itself can be traumatized, the whole healthcare team, and sometimes an entire institution is traumatized after an emotionally stressful event, depending on what that is. We also know that most of us, we've all made errors because we're human. And most of us do recover, as Brian has and I have, from the mistakes I've made. But we also know that sometimes recovery is thwarted. And that thwarted recovery can really have a negative impact both on the clinicians themselves and then subsequently on their patients. We actually were involved in a study where we looked at a cross-cultural study between the UK and the US site being the Brigham and Women's Hospital, where we did a survey study with interviews asking about the emotional impact of errors on clinicians, both nurses and physicians. And not surprisingly, many people were impacted for a long period of time. In fact, we found that 30% had a significantly negative impact on their relationships with colleagues and then their own performance at work. And that's a statistic to really key on, because that can translate into really downstream bad effects on both patients, families, and then clinicians themselves. It's also well known that there's a higher risk if you've made an error, or if you perceive you've made an error, of becoming burnt out or depressed. And so it's a vicious cycle where if you make an error, you can become burnt out. We also know that if you become burnt out, you have a higher chance of making a medical error. So we wanted to interrupt that cycle, as Brian was saying. And finally, we know from the literature that we're not very good, physicians in particular are not good around having compassionate and transparent disclosure conversations with patients after errors. Well, if you think about that, no wonder, because if you ask me to go in and talk to a patient and tell exactly what's happened and be compassionate, and I'm feeling ashamed and guilty and sad and fearful and isolated, the chance of my doing a good job at disclosure, a compassionate and transparent disclosure, is not high. Mm-hmm. And so we also feel that peer support could affect, in a positive way, the way we can show up for our patients, particularly after adverse events.
Mm-hmm. Thank you, Joe, and thank you, Brian. Joe, you've had the opportunity to start many peer support programs in different organizations. Do they all look the same? Is it a one-size-fits-all, or how can you tailor it to the different organizational needs?
Absolutely has to be tailored, I think. I think what's common, and as Brian pointed out, it's common that we're human, and so the error rates are the same across institutions. The kinds of emotions people feel are very thematic, as I said, although individual in the moment. So at least the underpinnings of peer support, the reasons to do it, and the kinds of outreaches are very similar from institution to institution. I think what's can be very different is depending on the culture of the institution and how people interact with each other. That will change how a peer support program is rolled out. And so for example, working with you all, it was very important for me to come and not talk about this is the way we do it and this is the way you should do it, but to think about, well, at Stanford, how do you relate to each other, and what are the ways of communication? What resources are available currently for physicians and other clinicians involved, for example, in errors, and how well are they utilized? Mm-hmm. So, for example, a lot of places do have a vigorous employee assistance program, but we found it at our institution that it was underutilized. Mm-hmm. A great resource, but not really helpful to physicians if they're not connected with EAP. Mm-hmm. Same thing with psychiatry. Really great. We have wonderful psychiatrists, but physicians weren't going to psychiatrists after adverse events. And so we have to understand at an institution, what do you have now for resources? Who's utilizing them? And who are people likely to connect with? And then tailor the program for that institution.